Very good afternoon, everyone. I am Dr. Varun and I welcome you all on behalf of Novo Nordisk. Today we have Dr. Sandeep Suri sir with us. He will take us through the novel aspects of the time in range as well as co-formulation Rhizodec. So before we start, I would like to give a brief introduction of Novo Nordisk as a company. So as we all are aware that as a company we have started our journey in just one second. So as we all are aware, Novo Nordisk started its journey in 1923. We have started our journey almost in parallel to the journey of insulin. We are 97-year-old company, stand tall in the field of diabetes. We founded our education foundation in 1997 and running various projects in public and private partnerships. I am also proud to say that half of world's insulin is nearly supplied by Novo Nordisk, and more than 30 million people across the globe, they are using our diabetes care products. When it comes to the innovations, we are always ahead. We are participating in a number of landmark clinical trials and programs, whether it is Boost, Leader, Dual, Onset, Devote, and many more. When it comes to the impacting through the innovations, we are always there, whether it is a number of clinical trials in the field of diabetes, where we are always far ahead from any other company, and also involvement of India as a country in the Novo Nordisk clinical trials. There are more than 200 plus investigators and more than 3,000 plus subjects. They were part of Novo Nordisk clinical trials from India as a country. When it comes to the various projects to improve the awareness, capacity, and treatment in the field of diabetes, we are running various projects like changing diabetes in children. For type 1 diabetes, for type 2 diabetes, we are running another project with the name of changing diabetes barometer. We are also contributed significantly in the field of continuous medical educational programs. We have also impacted the society through our quality products, and we are contributing each and every section of the society through our quality products, whether they are the human insulins or the insulin analogs or the next generation insulins. We have done an Impact India program in which we have given a 1000-day challenge to improve the status of the care. The doctor who have participated in this, they have gave their opinion that they would prefer insulin that provided total control with their convenience. So with this brief introduction, I would like to introduce our today's speaker, Dr. Sandeep Suri sir. Sir is currently working as at the Holy Help Hospital, Hisar. Sir has a keen interest in research. Sir is also working in the field of diabetology and decades of experience. Sir has been an investigator in the Indian Phenotype Registry, investigator in the EDGE study, also in the HbA1c Achieve study, and a number of many more clinical trials. Sir was a part of those studies. Sir is also very known academician and is a regional faculty for various diploma, NDP, Impact, CC, BDM programs. Sir has also a number of publications in high impacted national and international journals and been a frequent speaker at various scientific platforms. Sir has been awarded with the various awards. To name a few, sir is a recipient of Diabetes Awareness Award at Diabetes India 2018, Award for Excellence in Diabetes Care 2019 at RSSJ 2019. Sir is also recipient of Gold Medal at CMC Vellore. So with this brief introduction, I would like to invite sir to please take us to today's topic, achieving improved time in range, increasing possibilities through total control. Over to you, sir.
Yeah. Thanks for the kind words. And good evening, friends. At the outset, I must thank Novo Nordisk for organizing today's webinar and giving me an opportunity to share my views. And today we are going to discuss a very pertinent topic. It's a let me have it on the full screen. Okay, so from the start, from where to begin. Yes. So today we are going to discuss a very important, pertinent topic, which is clinically relevant and coming up in a big way, that is achieving improved time in range. And we will be also discussing increasing the possibilities through total control. What do you mean by total control of glycemia? Total control of diabetes. So these are two important topics we are going to discuss. Yeah. So my agenda will be moving through time in range. First, we will be discussing about time in range, a novel matrix beyond the gold standard of A1C that you all know. A1C has been the gold standard since many years from BCCT trials. This has been the gold standard of glycemic control that tells you about how much glycemia, how much glycemic control has been there with your therapies, with your medications and all diet and exercise related protocols during last 3 months. So this gives you an answer of 90 to 120 days of glycemic control, and it has been very well verified and validated. So secondly, we will go through the maintaining of glycemic harmony, improving time in range through total control. So first thing is that similar A1C but different glucose variability. So this time in range matrix of glycemic control, it comes from CGMS insight, continuous glucose monitoring system insight, that indicates that when we have two patients, as has been depicted here, with similar A1C of 8%, but they can have different glycemic variability. That means their glycemia will be variable. And this glycemic variability does not only include episodes of both hyper and hypoglycemia, but also there is marked intraday and interday variability of blood sugar value above the range of euglycemia, as has been clearly depicted here. So in era of evidence-based medicine, what is the status of HbA1c? Actually, with evidence-based medicine, we want the data should be verified and it should be unbiased. For HbA1c, it satisfies both things. It is unbiased, it is not related to mean, it is not related to time, the single value giving you the glycemic control of last 90 to 120 days. And it has been verified in all long-term trials that it is correlated with micro and macrosal complications. So for evidence-based medicine, HbA1c has got a value. But if you go deeper inside, if you dissect HbA1c, you are losing many things. You are not getting into hyperglycemia part, not getting into hypoglycemia part, and you are not taking care of the variability of the glycemia. So you are missing glycemic variability. So time in range is a new metric which is coming up in a big way, and data is building and consensus statements are coming up. If you look back to DEVOTE trial, that was the CVOT with Digludac, that was ultra long acting basal insulin analog, and it showed that the pre-specified pooled analysis, that was pre-specified pool analysis, that the increasing fasting glycemic variability, when you are not staying one fasting value, around one fasting value of 126 milligram, 110 to 126, you are having more variability. Fasting glycemic variability is correlated with adverse outcome as significant, and it is more significantly more severe. Hypos are there, increased major adverse cardiovascular events are there, and increased all-cause mortality. So simple variability in fasting plasma glucose is associated with these adverse events. So what do you say? How we manage? Are we not monitoring our glycemia before this time in range? No, we were doing it. But the thing was that, how we used to monitor it? We used to monitor either by getting patients fasting plasma glucose and postprandial 2-hour postprandial plasma glucose at the time when patient comes to you in the OPD. So it's a single click photograph. You resemble it as a single click photograph. Then you also advise self-monitoring of blood glucose to your patients. And this is more number of single click photographs. So initially you had 1 or 2 photographs, now you are having 5 or even 7 photographs of glycemia. So this gives you a sort of is the 5 or 7 photographs. So if you pick up all these photographs and make an album, like your birthday album or your marriage album, it will give you A1C, HbA1c, that is glycosylated hemoglobin, and it will give you information of around 90 to 120 days. So, but then we moved on to continuous glucose monitoring system. Continuous glucose monitoring system is a short, is a just like you are making a video with your mobile phone. video clip of say 20 minutes or 30 minutes, that gives you an information of 5 days of glycemia control. So here you have a device which is taking your interstitial fluid blood sugar, interstitial fluid sugars value 5 minutes every day, at every 5 minutes, 24 by 5 days. So for 5 days, you get every 5 minutes readings, and they are clustered together and they are collapsed together in a format. So this is CGMS, a short video. But now we are using ambulatory glucose profile, which I am using for last 3 to 4 years. Ambulatory glucose profile is just like putting your patient under CCTV camera. So that gives you an information of around 14 days. So these 14 days are the minimum 14 days which are required to have a information projected towards 90 days, further 90 days. So this is a sort of prospective management of glycemia, that you predict that this 14 days will be predicting your next 90 days glycemic variability and glycemic control up to the tune of 95% of truthness. So this is the minimum 14 days value. With these two newer advancements, that is CGMS and ambulatory glucose profile, you get one thing, that is range. You must be knowing that there should be one range of lower and upper bar in which your patient should be there to have a proper glycemic control, which you label as an excellent control or a good glycemic control in a safer way. So this is known as time in range. So time in range refers to time spent in an individual's target glucose range. Usually it is lower bar is 70 and upper bar is 180. But occasionally we give also 70 to 140, specifically in pregnancy. We go by 63 to 140 as a time in range. Now, it also gives you the percentage of time spent below range, that is below 70, or time above range, that is above 180. So this indicates hypoglycemia and hyperglycemia. So in between two, there is also glycemic variability from the median. Then time in range may be used as an appropriate endpoint in clinical research and as a measure of glycemic control in patients with diabetes. Now, there is an emerging evidence that suggests that time in range is inversely correlated to risk of developing micro and macroscopic complications. We are going to discuss in few seconds. So how you differentiate between HbA1c? Overall, I told you HbA1c is a type of album that you recorded with different photographs, and it gives you one value. So it evaluates single HbA1c value, whereas time in range is a continuous pattern. So here is very, you can say there is a very different thing that has happened from moving from HbA1c to time in range. We always talk about the mathematical value, that your patient is having 160 milligram blood sugar, patient is having 74 blood sugar, patient is having 64 blood sugar, patient is having 53 blood sugar, patient is having 250 blood sugar. But you are not able to visualize the trend, and you were not able to visualize the pattern. So this is what is time in range. That means it is just equal to your ECG. ECG is also a pattern of your heart. It is different electric conduction throughout your cardiac chambers, and they are replicated in the form of different waves. So that is a pattern. So time in range is also a pattern. So this is the difference between SMBG, this is the difference between HbA1c, and this is the difference on the spot blood sugar fasting, that you were evaluating only the value. Here you are knowing the trend and you are looking at the actual pattern. So HbA1c compares every 3 months, whereas time in range is compared any time period. HbA1c does not capture hypoglycemia or hyperglycemic levels occurring at the same day, and it gives you a trend of 90 to 120 days, and it more looks, and HbA1c more dependent upon your hyperglycemia part, and it never takes care of your hypoglycemia part. Whereas time in range captures all glucose levels for the given time frame, that at next. So in 14 days, what happened at between 8 a.m. to 10 a.m. every day, you are going to know by time in range. When you look at the profile from 8 a.m. to 10 a.m., so and for the 14 days, they are all 14 days reading are being collapsed into single 24-hour picture. So it's the beauty of time in range and beauty of ambulatory glucose profile, AGP and CTMS data that gives you collapsed value of 14 or 5 days into a single format of 24 days. And you can see that what happened on average 8 a.m. to 10 a.m. what happened to this patient's glycemic level. So it captures all glucose levels for the given time frame and it identifies the time within a safe range. HbA1c gives you immediate effect of therapy changes. It doesn't give you immediate effect, it takes time, whereas time in range gives you immediate effect. You can just check you alter the therapy, you alter dietary habits, alter physical activity, and you entered some increase one more medication, and you can see the effect within next 24 to 48 hours. So it's the beauty of time in range. With HbA1c, it's bad correlated to patient-related outcomes like hypoglycemia and hyperglycemia. They are not correlated, where time in range good correlation with patient-related outcomes. HbA1c has got high susceptibility to interference. So its interference are very high in HbA1c, specifically when you look at the Indian scenario where anemia is highly prevalent. Various laboratories, and they do different tests for HbA1c, so they have to be validated. HPLC method should be there. Anemia, age, pregnancy, CKD, specifically when you have eGFR less than 30, HbA1c value goes dicey. And basic principle is that it depends upon RBC lifespan. If your RBC lifespan is on higher side, it is more than 120 days, so you are going to have more than higher A1C. If your HbA1c lifespan, RBC lifespan is on lower side, like in hemolytic anemia, you will have lesser HbA1c falsely low. Whereas time in range, low susceptibility to interference. Only thing is that there is a lag time. There is a lag time between blood sugar values and there is a lag time in interstitial fluid. Now question comes, whether this interstitial fluid is correlated to your blood sugar value. Yes, that is definitely correlated. Now, which one is important? Blood sugar, we are tuned to blood sugar values of getting blood sugar values from the blood, from venous plasma or from arterial plasma fluid, plasma values, we are tuned for that. But in time range, we are looking at the interstitial fluid, whether interstitial fluid has got similar values as you have got blood sugar values. Actually, which one is important? If you look at interstitial fluid is much more closer to your target organ, and it's in comparison to your blood. So it replicates the effect of glycemia and the target organ levels of glycemia much more in comparison to your blood sugar. So in a way, you can argue that time in range that includes that ambulatory glucose profile and CGMS value that looks at interstitial fluid. So interstitial fluid has got better correlation to your glycemia at the level of target organ in comparison to blood sugar. HbA1c, good correlation to clinical endpoints, and has been validated in many trials, long-term trials, started from DCCT, UKPDS, and not many trials, and each and every CVOT has also looked at HbA1c value, whereas time in range, correlation to endpoints is unclear, hardly any long-term studies, but we do have some good information to share with you. So this is the information which I'm going to share with you that for time in range, microvascular complication, there are two studies, and these two studies are worth mentioning here. It is Vygotsky et al. Study, and that was published in Diabetes Technology and Therapeutics, and Beck et al. Study that was published in Diabetes Care. Now I will give you only the snapshot of 4 important information which you can get from these studies. Number 1 information, for every absolute 10% change in time in range, that means there is increase or decrease in time in range, it is correlated by 0.8% decrease in A1C. If you have got 10% increase in time in range, it is correlated by 0.8% decrease in A1C. So it's a prospective way of managing diabetes. Second thing, for every 10% decrease in time range, that means you are decreasing time in range, there is retinopathy increases by 64%, incidence and prevalence goes up by 64%, there is micronuria that increased by 40%, and diabetic peripheral neuropathy that increases by 25%. It's a very clear correlation with microvascular complications. But what about macrovascular complications? Now, people say that the postprandial spike has got definite correlation with macrovascular complication and also with microvascular complication. So time and range should have macrovascular complication correlations also. But to have macrovascular complication, you require long-term trials. But if you look at the surrogate marker, Verghese et al., they looked at carotid intima media thickness. So that is a surrogate marker of macrovascular complication. And this carotid intima media thickness, it is in between your hard cardiovascular endpoint and risk factor. So it's a 50-50 in between the weight. So it's a very important surrogate marker for cardiovascular endpoint. Now there's 10% increase in time or range will decrease carotid media thickness abnormal values by 6.4%. So clear correlation shows that time in range decreases macrovascular complication. Now, fourth important point is that if you are having some patient in 70% in time in range of 24 hours for 14 days or 5 days, his A1C can be predicted as 6.7%. So also if you have got time in range more than 80%, his A1C can be correlated by 5.9%. So this is a sort of prospective way that you can predict that if you stay in time in range for 5 days or 14 days, you are going to get this much amount of A1C control. So it's the beauty of these studies, and that I have told you the endpoint where these studies now stand. But we don't have long-term studies. I fully agree with you that we don't have long-term studies like 10 years cumulative incidence of developing diabetes-related complications, so correlating with time in range. Actually, we cannot have these much long-term studies because there is increased cost of CGMS. Secondly, you require larger study population that has to be there. Thousands of patients should be included here. So larger studies you require here. Secondly, it has to be longer time needed for sufficient number of CV events to happen. So that's how you can get macrovascular benefit, macrovascular related endpoints. So such studies, you can say longitudinal design studies to happen in the near future are not possible with CGMS. But what we did here is very beautifully depicted here. What we did here to have time in range correlation with long-term diabetes complications, we use IQVIA. That is, it's a IQVIA core diabetes model. It's a computer-based software application. And we tried to use time in range as the only variable. We removed all confounder like smoking, hypertension, dyslipidemia, and age. We removed all, only looked at the one part, that is time in range. And it clearly shows that the diabetes-related development of complications after improving time in range, as depicted here, you move from 58% time in range to 70% to 80%, whether you are dealing with type 1 diabetes or type 2 diabetes, at all complications, myocardial infarction, end-stage renal disease, severe vision loss, and amputation, they are all showing a very clear improvement and clinically significant and statistically significant part that has been shown with all these complications when you put your patient in increasing incremental time in range. So this is from that computerized model of having diabetes-related complications application. Now, looking at this data, recently ATTP, that is Advanced Therapeutics and Treatment in Diabetes, and also by ADA and ESD, consensus statement of time in range has been placed, and as an important glucose matrix from CGMS and AGP data, and the time in range has been put forward as time in range and the amount, that is how much. One is target range has been decided, that is target range, and then how much time in 24 hours you spend in this target range. This is known as time in range. So here in type 1 and type 2 diabetic patients, You fix the time in the target range of 70 to 80%, and you require that out of this target range should be there in more than 70% of your 24 hours. That is 16 hours to 0.48 minutes, because every 15 minutes you are getting one reading. So from AGP, so 16 hours to 48 minutes should be of this 24 hours should be there in target range in all type 1 and type 2 diabetic patients. Now in older high risk type 1 and type 2 diabetic patients who are very high risk for hypoglycemia, you have to have liberal targets. So time in range is same, 70 to 80, but target range is same, but time in range is decreased by 50%, and you have to be there at least for 12 hours a day in target range. Regarding pregnancy in type 1 diabetic patients, pre-pregnancy diabetes, type 1 diabetic, the strict 63 to 140 is the time target range, and it requires more than 70% of 24 hours should be in the time range. And for pregnancy GDM type 2 diabetes, we require more specific studies to fix the target range, but still I feel that this target range should be there, like 63 to 140 milligrams should be the target range, and we should have similar like in type 1 diabetes, pregnancy related, like more than 70% should be there. It's my own feeling, which I try to achieve in my own patient. So, but if you're overshooting, like you are having time above range, then there are two targets, that up to 140 to 250 is one range, and above 250 is very high hyperglycemia. So high hyperglycemia and very high blood sugars or very high hyperglycemia. So 24% can be there, but it should be less than 24% of the time of the 24 hours. That is less than 6 hours. You can go about 180 to 250. Otherwise, above 250, it should be less than 1 hour. Never go 5% beyond 5%. It should be less than 1 hour for above 250. Whereas for older people, there is again similar thing. That is, you can up to 50%, you can go up to 180 to 250, but less than 10% or less than 2 hours should be there for 250, above 250. So there are liberal targets with high risk type 1 diabetic patients who are having so many comorbidities like diabetic kidney disease and retinopathy. So have to be liberal targets, and older population also. Pregnancy related, it should be very strict. Less than 25% should go beyond 140. So similarly, in pregnancy GDM, we should have similar targets of going above 140. Now, if you are going below 70, that means 70 to 54 is one range, and below 54 is another range. So if you are having 70 to below 70 to 54, only you are being allowed to have less than 4% in a 24 hours. So it should be less than 1 hour in a day to go below. And if you are going below 54, it should be only less than 15 minutes. So these are important targets. So basically, they are somewhat more swaying, that they can accept some amount of hyperglycemia, but hypoglycemia is absolutely unacceptable across all the range of your patients. So you can have this screenshot of this international consensus for PGMS data for interpretation. Now, what is the nutshell, or you can see the key points to emphasize here for type 1, type 2 diabetic patients. Achieve goals for both time below range and time in range. First priority is to reduce time below range, because you have to prevent hypoglycemia to the target levels, and thereafter address time in range and time above target. For older population, you can have somewhat more time above range, but definitely try to avoid time below range. For pregnancy, safety increases as you stay with the time in range at the earliest stages of gestation, while reducing time above range, and glycemic variability should be your target. Now, pregnancy gestation in type 2 diabetes, I told you more data is needed, more specific trials are needed to pick up that time in range, but I think it should be just like pregnancy in type 1 diabetes. Now, this was the brief of my explanation towards time in range. We can answer more questions in the question answer session. Now, going to maintaining, second part of my talk, maintaining glycemic harmony, improving time in range through total control. Now, what is this total control? See, now, when we started treatment of our diabetic patients, we moved from glycemic trials. initially we fixed that glycemic triad. What is that triad? That is fasting. You fix fasting plasma glucose, fix postprandial glucose, and also control A1C. So it's a three factor, that is glycemic triad. Then we moved on to glycemic pentad. That included two more factors, that is glycemic variability, intraday, intraday, time to time change in glycemia, and also improvement of quality of life, that is glycemic pentad. But now we are thinking that we should target at glycemic hexad. That included one more factor, that is avoidance of nocturnal hypoglycemia. So this is known as total control of glycemia. Managing patients towards glycemic hexad is total control of glycemia. So here is your patient. It's a case simulation study, 50-year-old patient. He has computer engineering, 7 years of history of type 2 diabetes, diagnosed with hypertension 1 year back. He is on linagliptin, metformin 2.5, 850 milligram B dose, limitride 2 milligram OD, losartan 50 milligram OD, atorvastatin 10 milligram OD. BMI is obese, A1C is on a high side, 8.8, FPG 158, postprandial glycemia 262, and he has got tingling sensation in lower extremity. So you interpret four things in your patient. Patient is obese, he has got 7 years of history of diabetes, he has got A1C on a higher side that requires control, 8.8. He has been on good amount of oral anti-diabetic drugs, that is already he is on 3 OADs, that is there. He has got increment in fasting plasma glucose to postprandial plasma glucose by 100 milligrams. So this much amount of mathematics you have to do in each and every patient. So it is the spike, postprandial spike is more than 100 milligrams, and he has got complications like diabetes peripheral neuropathy. So these are important things. Now, how to control his glycemia? You can add one more drug. Why not to have fourth drug like SGLT inhibitor? Will you get benefit? I think you will not get benefit, because here, if you add even SGLT2 inhibitor, 8.8% A1C, you are going to decrease A1C by the tune of 0.5 to 0.8%. You will not get below, at any cost, you will not get below 7.7 or 7.5%. You will not get below that. On average, you will have 0.5 to 0.8% decrease by SGLT2. So here you require insulin. That should be there. As from RSSDI ESI guidelines, insulin therapy should be considered in all patients failing to achieve glycemic target on 3 oral anti-diabetic agents. No fun in adding another fourth drug. So this is also in another poster presentation at ESD, that the landmark trial is another poster presentation from Indian continent, from Indian patients. More than 5,000 patients are there, and 6 months data has been published as a poster presentation. It was presented at ESD, and then Dr. A.K. Das and Dr. Shashank Joshi, and they showed that addition of fourth drug will give you benefit of only 0.5% in A1C. So there is no fun in adding fourth drug. So this is the appropriate time. Rather you are late, but it is an appropriate time to initiate insulin. But insulin has been always put as a sort of, there is always a insulin related therapeutic inertia, or it's a sort of clinical inertia with this insulinization. But one thing very importantly that has been alluded in RSCI ESI consensus statement, that we all should avoid using insulin as a threat or describing it as a sign of personal failure or punishment, and should work to alleviate patient-related anxiety about hypoglycemia, dependence, injection site pain, or related increase in complications like retinopathy, CKD will increase with insulin, or myocardial infarction will increase with insulin. So such type of myths should be removed at least by now, because now we are entering into 100th year of, next year we are going to celebrate 100th year of insulin. So I think we should be absolutely clear that insulin resistance that is there in our mind, that is psychological insulin resistance, it should now go away at any cost. We should have diabetes educator with us. Now the theme of IDF, it's World Diabetes Day, is nurses in management in diabetes. So we should have diabetes educator, diabetes nurse with us. It should be trained, and various courses are going on. and they are free of cost, like NDP program, which I am conducting at Hisar. So by around third time I am conducting that program, and 20 to 25 students they are there. So we can have such type of training programs, and you can educate your staff for having a insulin regarding insulin education, insulin techniques, and elevating patient-related anxiety. So they can be very helpful for you. It's a team approach basically, and with this you can increase the acceptance and adherence to insulin. Now there you can start insulin with various ways. You can start with basal insulin. You can also start with the premix insulin analog or premix insulin. But there is one more option, that is you can initiate insulin with OD dose of IDEC aspart looking at the major meal. So it's a meal related IDEC aspart, that is a co-formulation. So we are going to discuss about this IDEC aspart, how it is able to give you the total control of in your patient. And with start initiating with IDEC aspart OD dose, you can intensify very well with BID dose of IDEC aspart. Now, IDEC aspart is an insulin co-formulation. What is the co-formulation? If you look at just looking at this, the blue mark is basically your basal insulin, and then there is a postprandial rise. This is is a physiological insulin profile. Now this is your co-formulation that mimics the physiological insulin secretion very closely, unlike the basal insulin alone. So here you have got two components, that is no effect is there, that is the part is there, and then there is another non-active, that is the glucose is there, and these co-formulations, these two insulins are there in a single device, but they are not mixed with each other, they are not interacting with each other, they are not related to their pharmacokinetic and thermodynamic profile. So this is how you can justify this co-formulation to different than your premix insulin. And there is no interaction to pharmacokinetic and thermodynamic profile of insulin or premix. So now,
Sir, Sandeep, sir, there might be some device is placed near your system. Some echo is coming.
I am audible?
Yes, sir. Now it is perfect, sir.
Okay, so I can start now. So then to if you use with premix insulin, this is premix insulin. So here you find that there is a shoulder effect. That means there is an interaction between no mix or no mix 3070. There's a rapid acting insulin that interacts with intermediate acting aspart insulin, that is protaminated aspart insulin. And after 6 hours of the duration, there is an interaction between these two molecules, and this is known as shoulder effect that can lead to hypoglycemia. So this is not seen with this co-formulation. So it's not a mixture, it's a co-formulation where two individual molecules, they are remain separate as such as per their pharmacokinetic and their thermodynamic profile, and there is no interference in between these two molecules. Whereas if you are using premix insulin, there is a definite interaction between regular acting or rapid acting insulin and intermediate acting protaminated aspart insulin. Now this is basal bolus therapy, which is also not akin to your physiological insulin. So by using IDEC aspart, you can have various benefits in pharmacokinetic and thermodynamic profile of insulin, mimicking better like your physiological insulin profile. Also, if you look at whether IDEC aspart can be a okay, so IDEC aspart can be a pragmatic solution to Indian realities. Indian glucophenotype is very different than your Western or Caucasian counterparts. Number one thing is difference, that 65 to 70% of calories that of our diet that comes from carbohydrates, and maximum of this comes from refined carbs. So we are carb people. We do consume many carbs throughout India. So India is united as per the carbohydrate intake is concerned. Then when you consider insulin addition or using insulin, we are very late in initiation of insulin. It is always impact program has already told you that we can start thinking about insulin when your A1C is more than 9.3%. So very late in initiation of insulin. And our postprandial glycemia is maximum contributor to our A1C profile. And also there is increased postprandial excursion to similar carbohydrate diet in comparison to Western and Caucasian population. So IDEC aspart, it provides total control, effectively addressing both fasting hyperglycemia without neglecting postprandial hyperglycemia. Secondly, IDEC aspart tackles high carb diet with the major meals. So we can start with one insulin, we can stay with one insulin. There is one injection, one device, and one site, and one titration algorithm. All these are going to remove your clinical inertia regarding insulin initiation, optimization, and intensification. And also, due to its very good pharmacokinetic and pharmacodynamic profile, it allays the fears of hypoglycemia with the major meals, and it suits the dietary pattern of Indian scenario. And beautifully, there is an excellent pen device which are going to show you that there is a flex touch device which has got unmatched accuracy and least gliding force or injection force. So in where we should use this co-formulation at all type of patient, type 1 and type 2 diabetic patient age more than 18 years, whereas Tresiba can be used even 1 year of the age, but Rhizodec currently it is to be it is advised, DCGI is approved more than 18 years of age, elderly patient with type 2 diabetes, type 2 diabetic patient with renal and hepatic impairment, and type 2 diabetic patient with other comorbidities, because it has got absolutely smoother pharmacokinetic and pharmacodynamic profile that is not altered by decreasing EGFR and decreasing or impaired hepatic functions. Also, you can start and stay with the therapy. Patient uncontrolled on OADs, patient uncontrolled on basal insulin, you can shift your patient exactly similar dose to your this IDEC aspart. Patient uncontrolled on premix insulins, again you get the benefit of better control of hypoglycemia. And also patient uncontrolled on basal bolus therapy, decreasing number of pricks, decreasing amount of insulin, decreasing hypoglycemia, and decreasing weight gain. So these are the obvious benefit when you use insulin co-formulation. And also now the cost has also gone down recently. They have decreased the cost by 30%. And also now this Rhizodec or this co-formulation is available in the form of pen fill that can be used with NovoPen 4. And so now these are two more things that has come up with Rhizodec. Now, insulin initiation, we do have a trial, that is Onishi et al. Trial, that gives you an information that was published in Diabetes, Obesity and Metabolism in 2013. And here, which insulin to choose when patient is uncontrolled on OAD? This was the question answered, and this is the trial where the two arms were there. One arm is IDEC aspart OD plus minus OADs, 147 patients. Second arm is insulin glargine, that is a gold standard basal insulin, insulin glargine U100 OD plus OADs. So what happened? And it was a 26-week trial. So what happened, that fasting plasma glucose is similarly controlled in both arms. There is similar control, and A1C control is somewhat better with IDEC aspart OD dose. It is, the control is up to 1.4% of A1C from the baseline, whereas it is only 1% from the baseline in OD glargine U100 with OAD. So if you look at the A1C benefit, it is definitely there with in IDEC aspart in comparison to OD glargine U100. And also, so this when you looked at coming back to your patient, you had one trial data. Now you want to apply to your patient, but look at the ambulatory glucose profile of that patient, Rajesh, 50-year-old. Clearly, you can see here that there is a spike after this let me have marker also, that I can tell you that laser pointer. Yes. Now this is the median of the graph. This is the target range 70 to 180. Here this is 10th percentile. This is 90th percentile. These are gray zone, lighter gray zone. These are darker gray zone, which is 25th percentile and 75th percentile of the reading. And this is median. It is not mean, it is the reading median, because there is a glucose is a variable quantity is there. So we cannot have an arithmetic mean. It's a median. So this is the median line, and you can see there is a definite fluctuations, and the readings are going above when around 12 a.m. in the morning, around the noon, and here this patient is consuming breakfast. So clearly showing you that your patient is having postprandial spike after the breakfast. Now going back to that trial where Onishi et al, they looked at the major meal, and the major meal in this trial was for the dinner. So they started with idegespart before dinner, and they saw that fasting plasma glucose is absolutely same in both arms, but A1C is better, I told you, and there is postprandial control post dinner by up to the tune of 60 milligram. So idegespart addresses postprandial spikes after the major meal that was missing by basal insulin. That's why you are getting better control in A1C with this trial, with idegespart in comparison to your OD glargine U100 in plus minus OADs. Now also there is another benefit with this that has shown that you are getting 27% decrease in overall confirmed hypoglycemia, and also 25% decrease in nocturnal confirmed hypoglycemia. But these are not significant statistically, but highly clinically relevant endpoints. Also important, less than 7, if you are able to achieve less than 7%, so this was the target, to achieve less than 7% without hypos, A1C achievement without hypos less than 7%, it was possible in 43% of your patient on idegespart OD dose plus minus OAD versus 25% patient with glargine U100 plus minus OAD. So there is 72% more patients were able to achieve targets without experiencing hypoglycemia versus ideglargine U100 OD dose. So this is the beauty of this trial that has shown that you can achieve glycemic control with this molecule idegespart in comparison to insulin glargine U100 if you stick to the major meal in single day insulin injection. Now we started with insulin idegespart before breakfast in this patient, because breakfast was contributing to maximum glycemic spike as from this ambulatory glucose profile picture. So OADs were modified, linagliptin metformin was continued along with the drugs for hypertension. Dose of glimepiride were reduced to 0.5%, 5 milligram VD dose to prevent hypoglycemia related issue. So idegespart 10 unit with the breakfast was started because it was the largest meal for this patient, and it titrated upwards. Titration was done to look and we titrated with the pre-meal and post-breakfast in blood sugar values, and also with the fasting plasma blood sugar values. So here we titrated up to 18 units of idegespart over 12 weeks, and after 12 weeks, what you got A1C decrease from 8.8% to 6.9%, and body weight remains same. So this is the beauty of this Onishi et al trial. So this is the beauty of that flex touch pen. There is no push button. It's excellent device. No end of the dose click. You can go up to 80 unit per dose in a single dosing system. So this is, and very less dexterity is required. Very low dose force is required, and glide force is at least is less than 70%, 50 to 70% lesser than other companies' devices. So it is an easy touch button control device. It's a beautiful device that is flex touch device, but you can have a pen fills also of Rhizodeck that can be put into Novo Pen 4. Now, how to optimize? You initiated, then you optimize the dose up to 18 unit. How to titrate the dose of Ideg-Aspart doses? Ideg-Aspart, if you are using at the bedtime, it is titrated according to your fasting plasma glucose. And if you are using in a BD dose of Ideg-Aspart, it is based on the pre-meal and post-meal values. Always try to have +2 or plus 2, not go beyond 2 or 3 unit per alteration, and try to fix the dose between 80 to 130 milligrams should be the breakfast, and post-prandial should not go beyond 160. So try to stick in the target range, and +2 or +3, +4, you can up titrate as your confidence grows up. So it's a more of art than the science of up titration or optimization of Ideg-Aspart. But need is, don't stick with the only initiation. You have to optimize your therapy. Here again, a clinical inertia comes into picture. It's a beautiful molecule with least amount of hypoglycemia, excellent pharmacokinetic and pharmacodynamic profile. So it's a very easy to optimize, and you should build your confidence towards optimization of Ideg-Aspart to reach to the targets. Now, once you started with this molecule, before breakfast, you can clearly see here that now your postprandial spikes, which were there, has gone off, and this was the picture of ambulatory profile, that you are having this hyperglycemia zone. Then there was before lunch or before evening, early post lunch also there was some sort of hypoglycemia. So there was erratic control, and time in range was only 74%. That was sufficient for this patient. But if you try to achieve better glycemic control in this patient, you should try to improve, because time above range was 21%. So can we get much better control with Ideg-Aspart? Now you can see here, improved time in range, absolutely stable median, putting into stable median throughout this profile, everyday profile. You can see that median is absolutely stable. You are achieving the target glycemic control. You are achieving time in range from 99 to 100%. Time below range is absolutely 0, and time above range is nearly 0. So this is the beauty of this molecule when you initiated with with maximum contributing meal OD dose of Ideg-Aspart. So you can start with basal insulin analog also, basal insulin in this patient, but issue is that only 50% of your patient will be achieving target of glycemia of less than 7% when you stick with basal insulin. Also, if you try to up titrate the dose of basal insulin, you cannot go beyond 0.5 unit per kg body weight. And if you are achieving the target of FPG, fasting plasma glucose, of 110 to 120, still you are not maintaining A1C. It is always go to either basal bolus, basal plus 1, basal plus 2, or basal bolus, or you have to add GLP-1 analog. So there is always a sort of up titration you have to do with, if you are sticking with basal insulin. If you are starting with basal insulin, you can manage accordingly like that, but there is a definite treatment inertia, and it is more complicated therapy. Why not to start with a single insulin, single device, single site, and stay with this? You can up titrate with this also, and that means you are now moving toward intensification with the co-formulation. So this is the trial, that is Simicas et al. They published this trial in Diabetes Research and Clinical Practice, and they this was a study of 532 patients. There was 2 arms, Ideg-Aspart plus OAD plus oral antidiabetic drugs. It was 267 patients. Then it was 26-week trial, initial treatment titration period, then treatment intensification period. Treatment titration period was of 26 weeks, whereas further there is up to 58 week you went towards treatment intensification period. 2 arms, one arm with Ideg-Aspart plus OAD, another arm again insulin glargine plus insulin aspart. So now you are having basal plus regimen, and you are moving from basal plus to basal plus 1 to plus 2 plus 3, or basal bolus therapy along with OAD. So this is the up titration or intensification of insulins. Whereas with insulin Ideg-Aspart, you are moving from OD to BD dose of Ideg-Aspart. You can also go to idegespart TID, TDS dosing. Very small amount of idegespart can be given at the time of lunch also. In between these two insulin injections, there should be a gap of 8 hours to prevent the stacking of insulin aspart in idegespart. So is a component of insulin aspart. Otherwise, there is no stacking with Tresiba or no stacking with degludec insulin. It's only with premix insulin. It is only with the bolus insulin there is a stacking part that is there. So you can even go with the TDS doses of idegespart. But here in the trial part, idegespart was given as a BD dose. So what you got, HbA1c was same. So you can argue here, when you are achieving same HbA1c, why to go to this somewhat costlier insulin? Once you are, so the dictum is that if you are comparing two insulins, never look at HbA1c value. You can achieve similar HbA1c with any insulin. It is only the safety issue. It is only the safety issue of the insulin that determines the capacity or the safety or the beauty of insulin. So if you're looking at A1C, you are getting similar A1C in the both arm. If you're looking at fasting plasma glucose, you are achieving similar fasting plasma glucose in the both arms. But now look at the confirmed hypoglycemia. It is numerically lower. It is 10% decrease up to 26-week period and 14% decrease up to 38 week. So it is not statistically significant, but numerically lowered, and these are all clinically relevant endpoints. May not be statistically relevant endpoints. Now look at the nocturnal hypoglycemia. Nocturnal confirmed documented hypoglycemia. There is significantly lower, that is 45% decrease in nocturnal hypoglycemia by 26 week, and there is 39% decrease in nocturnal hypoglycemia by 38 week, clearly showing that achieving targets with co-formulation is much more safer in comparison to your basal bolus regimen. So again, now you moved from 8% HbA1c to 7% HbA1c. If you are using insulin glargine U100 plus insulin aspart as a bolus, basal bolus therapy or basal plus therapy, 46% increase in patient related or predicted hypoglycemia rates, patient years as per patient's years. So predicted hypoglycemia rates are increased by 46% if you are using basal bolus, basal plus therapy, and if you are using idegespart, there is somewhat increase in hypoglycemia. Definitely it will be there, because inherent part of hypoglycemia is an inherent part of this insulin therapy. So we will be having, but only up to the tune of 19%. So it's a much more lower, much more safer insulin in comparison to your insulin glargine basal plus or basal bolus therapy to achieving the target when you move from 8% to 7%. Now, so idegespart balances efficacy, safety with convenience as compared to basal bolus regimen. Same study showing that at 36 week, A1C control was same. Overall confirmed hypoglycemia was same, but numerically there were higher hypoglycemia with insulin glargine plus bolus therapy. Nocturnal confirmed hypoglycemia was significantly lower with idegespart. Total daily dose of insulin goes down significantly lower with idegespart. That means cost saving comes into picture. Lesser amount of hypoglycemia, lesser weight gain, lesser amount of insulin going into your patient's body. So lesser chances of any adverse event related to hyperinsulinemia. So total insulin dose going down, total number of injections going down. So better patient compliance will be and better adherence will be there. Ultimately achieving better targets will be there when you are using idegespart versus insulin glargine U100 plus insulin aspart plus 1 plus 2 or plus 3. Now applying this data to another case study, type 2 diabetic patient since 9 years of history. So, and history of MI is there. So this and he's hypertensive, poor blood glucose control, on treatment with basal insulin plus OADs. You are having metformin, empagliflozin, glycoside, and you are on insulin glargine U100 25 unit OD. So what do you want in this patient? Look at the ambulatory glucose profile in this patient. You can see that you try to increase the dose of insulin glargine to achieve the glycemic control, but you are getting a sort of, you can say, the dawn phenomenon, Samogai phenomena type of picture is there. So there is nocturnal hypoglycemia, early morning hypoglycemia, and then there is a picking up of hyperglycemia at the time of breakfast, and early morning hyperglycemia is there. So this is the picture. And another on April 28th, the ambulatory glucose profile was put. Then April 29th, you again next day you can see that post breakfast, post lunch, post dinner, all are on the higher side. You are not going to get the targets with your basal insulin only. Again, similar thing is replicated in April 3rd on next day ambulatory glucose profile. And the target mean blood glucose was 144, 187, and 163. And look at the time in range, only 40%. Some day it was only 5%, and next day it was only 21%. Now you started with IDEC aspart before breakfast. Here you can see that mean blood glucose was 167 on the day 1 of initiation of IDEC aspart, but by day 3 after initiation of IDEC aspart, you are getting mean blood glucose of 106 with 88% of target time in range. And now you can move up. Still, if you are having hyperglycemia before dinner, after dinner you can have another dose of IDEC aspart before dinner, and this will improve your time in range. So summarizing today's talk, time in range provides a closer view of person's glycemic status, and it definitely aids into better glycemic control. IDEC aspart, it addresses the common reality of high carb intake in Indian scenario, high postprandial excursion and postprandial glycemia in Indian scenario. IDEC aspart offers improved time in range by providing total glycemic control, hitting at the glycemic start with safety as insulin initiation, optimization, and intensification option. IDEC aspart offers flexibility and is an as simple and convenient solution that can fit into patient's life of people with type 2 diabetes even during insulin intensification. So it's a beautiful molecule, and I'm really thankful to you for patience hearing, and I'm willing to answer any queries or any questions here.
Thank you very much, sir, for answering, for taking us through this time in range concept and correlating it with the co-formulation, how that will be able to make the glycemic levels in time in range. So now we can open for the question and answer session. So I request the audience, they can put their questions in the question section. So to start with the like we have discussed this novel concept, but as we are aware that India as a developing country, we are still struggling with the insulin inertia. So what do you feel, how it is practical to implement this time in range concept to our country?
Okay, so practicality of time in range and practicality of basically CGMS and ambulatory glucose profile, this you want to know. Okay, so Dr. Varun, still there is an inertia towards self-monitoring of blood glucose. So we are not accepting even SMBG in type 2 diabetic patients. So there is lot many inertia, and if you see, if you take you can a poll that how many of us are asking of looking at asking for self-monitoring of blood glucose at home to our patient, it is only 10% of us, only 10% of us. So still there is a lot of thing has to be done, but you know this technology has to be accepted, and it is going to be accepted. I tell you, this is going to be accepted like anything. There are 3 myths regarding time in range, regarding CGMS, regarding this ambulatory glucose profile. So few myths I have cleared. One myth is that whether it is a proven thing or not, whether it is correlating to your landmark trials, whether it is giving you outcomes towards the management of glycemia, whether you are having relation towards micro and macrosal complications, this I have alluded to you. Another trial is hypo-DE study. This trial showed that if you rely on time in range, you are going to decrease hypoglycemia, severe hypoglycemia, or even total overall hypoglycemia up to the tune of 72% in 1 month. So it's an excellent tool to decrease hypoglycemia, to improve patient safety and patient's compliance. Similar, next myth is that it is difficult to use and understand. So this was the initial my thought when I started using ambulatory glucose profile 3.5 years back. But I tell you that it is so easy that even your patient can see how much glycemic fluctuations are there in your day-to-day profile. What happened on 12th November at 10 a.m. What happened to my blood sugar level, what I was doing at the time of my breakfast, whether I went to my gym, whether I was doing some exercise at night, I went to marriage, I consumed something, I had Saturday night party, I consumed something, and that led to glycemic spikes. So this is a sort of strong educational tool to your patient that if you are doing like this, you are going to have bad glycemic control, and if you are doing this, you are going to improve glycemic control up to the tune of 40 to 50 milligram. So this is the beauty of this. It's absolutely painless, weightless device which is there on your left arm, and you can have this for 14 days, and there is no issue related to compliance to ambulatory glucose profile. Second thing is, it is too expensive. Now look at the cost of hypoglycemia management. Severe hypoglycemia patient admitting to you in your hospital, look at the cost of total therapy and discharge. It is more than 20,000. It is more than 20,000. Whereas for single 14 days ambulatory glucose profile picture, it costs only 2,500 to 3,000 at my center. So it's absolutely cost effective, and you can clearly predict. It's a way of managing diabetes in a prospective way, that you can predict कि 90 दिन में आगे क्या होगा. So by 95% of accuracy. So this is the beauty of this molecule, this thing.
Thank you very much, sir, for nicely explaining the practicality of this time in range concept and how we can use this ambulatory glucose level and CGM in our day-to-day practice. So thank you very much. I cannot see, sir, any further questions, and we are also very close to the time. So I think we can close this meeting here. So before closing, I would like to request you for concluding remarks for the day, sir.
Yeah, only thing I want to say that this is a very clinically relevant tool, specifically when you see that there is a discordant in SMBG and there is discordant in HbA1c value. Your patient is prone to hypoglycemia when you are dealing with the elderly population, dealing with CKD patient. These are really boon in type 1 diabetic patients when you want to avoid nocturnal hypoglycemia or even overall hypoglycemia, because these can lead to hypoglycemia unawareness, and that can be a very dangerous thing, very tough thing to treat. And also in your patient who are having diabetic neuropathy, autonomic neuropathy, they are very highly prone to hypoglycemia related cardiovascular events. Patient having high risk of cardiovascular comorbidities like cardiovascular disease, or CKD patients high prone to hypoglycemia. So this is the time in range ambulatory glucose profile is a really excellent tool, and I request you all, please try to use it, and try to use those molecules which are giving you total control in glycemia. So this Rhizotec molecule is again a very beautiful, very nice molecule, very smoothly controlling, and its pharmacokinetic and pharmacodynamic profile remains absolutely same whether you are dealing with CKD patient or hepatic impairment patient. So very minimal amount of hypoglycemia with excellent control of both fasting plasma glucose or basal glycemia and postprandial glycemia. Thank you for patience hearing.
Thank you very much, sir, for such a wonderful presentation. And thank you, and have a happy Dhanvantri Jayanti today, the day of God of Healing from India.
Varun, happy Diwali to all. Happy Diwali to all of you.
Yes, sir. So happy Diwali to you and to everyone. Happy Diwali. So thank you very much.
Convey my greetings to your family also.
Sure, sir. Thank you, sir. So thank you, everyone. Bye. Bye.